Good morning, everyone. If I could have your attention, we're going to get started. So if you would, please take your seats. So I'd like to welcome you all to the 2019 Employers Health Annual Meeting. I'm Chris Goff, CEO and General Counsel, and before we get started with the business portion of today's meeting, I'd just like to share a few housekeeping issues. A PDF of today's presentation is available on the Employers Health website at employershealthco.com/meeting-materials. Additionally, today's meeting will be recorded and shared on the meeting materials page of our website. You also receive an electronic evaluation after today's meeting, so we would ask that you please take a few minutes and complete the evaluation so we can use your feedback to improve upon future events. And also, for the benefit of the attendees in the room and the attendees who might be watching this on the web, or in fact we're live streaming this as well, if you have a question during the Q&A, we have a couple of people with microphones. If you would hold your question until the mic gets to you, that way everyone can hear what the question is. And now I'd like to transition into the business part of our meeting. We have a slate of 3 individuals who have been nominated to serve a 2-year term on the Employers Health Coalition and the Employers Health Purchasing Corporation Board of Directors as recommended by the organization's nominating committee. Those nominees are Guy Petra from Dover Chemical Corporation, Mark Sponseller from Alfred Nichols Bakery, and Tina Spiker from First Energy. Could I have a motion to accept that slate?
I'd like to make a motion to accept that slate.
Thank you. And a second?
Second.
Thank you. All those in favor signify by saying aye. Any opposed? And just for the record, proxies were proxied to me, and so I will vote in the affirmative as well. Before I introduce our speaker, I'd like to recognize an outgoing board member who is retiring from the board, and that is Mark McLeod. And Mark has been with us for 19 years through 3 employers, and he is retiring in mid-January from Oberlin College and Conservatory. Mark, would you come up for a moment? So 19 years doesn't get you 1 gift, but gets you 2 gifts. But I just want to recognize Mark because he's been a tremendous asset, very valuable, offers great counsel and advice, and I really want to thank you for 19 years of dedication to the board.
My pleasure. Thank you. Wow. Thank you.
Next, I'd like to introduce our speaker. And our speaker is Seth Serxner, who is Chief Health Officer and Senior Vice President of Population Health at Optum. He has more than 25 years of experience in health and productivity management and serves as a reviewer for peer journals such as the American Journal of Health Promotion, Journal of Occupational and Environmental Medicine, and Health Affairs. Please join me in welcoming Seth.
Good morning, everyone. I'm on West Coast time, so by the time this is over, I'll start to wake up, but hopefully everybody else is raring to go. I'm also a bit of a pacer, so they told me I could be down here and walk around a little bit. So welcome. Thank you for making the time and effort to be here today. I'm going to cover a lot of different ground this morning, but I'm just curious again, how many in the room are employers with specific companies? Okay, great. And then we have some kind of consultants, I guess, or some consultants or brokers, or okay, a few. Some health systems, maybe? What'd I miss? Staff. Right. Okay, great. Let's see if we get this going here. Excellent. So the first thing that I wanted to talk about, I'm going to kind of move from a little bit about population health and well-being, and then I was asked to talk a little bit about behavior change and some of the science around behavior change. I was really, frankly, quite pleased to be asked to talk about this topic that I don't think people spend enough time talking about, because at the end of the day, that's really what we're about. We're trying to help people change their behavior. But one thing that I have noticed and I think is evolving, I'm curious to hear from the group a little bit about, is the value proposition of what we've been doing lately seems to have shifted a bit. It seemed to have shifted from kind of an ROI and it's all about healthcare costs to more of a, what we'll call a value on investment. So certainly people are saying, yeah, I want to, if I could, it'd be great to have healthier people, save me some money. But really what we're starting to do is see people shift to a human capital perspective, that I can't get my business done unless people are focused and not distracted and have good energy. So I'm curious, and maybe people can kind of start to raise their hand as I move along the continuum. And I also know that it's not an all or none, but I'm curious how many people feel like, and you know, again, no judgment here, but that the main reason you're making investment in this area of population health and well-being is for an ROI piece. How about improving health? You can keep your hands up or start to put it. Improving health of the population? How about productivity? Is productivity part of it? What about this human capital? Any of you feel like it's just a big part of your business strategy? This is a little exercise too. Your arm's getting tired yet. You can wave them around a little bit. So it's just interesting to me, and I'm, as I think I mentioned, the West Coast, I'm in the San Francisco Bay Area, Silicon Valley, and those employers are really about recruiting and retaining and keeping people focused. But again, there's a whole range here. The other thing that, you know, we'll drill down on this, but I really think about population health. So as we think about what our jobs are in this space, and we think about the entire population from the continuum of well to at risk to condition to catastrophic or complex, what are the programs and services that align with each of those? Who is in there? We know that on the right side, the complex, you've got a very few amount of people driving lots of costs. But on the other side, we have a lot of people not driving many costs at all, and we want to keep them that way. So part of the goal is to keep the well people well, manage the people that are kind of at risk from not crossing over to chronic, and then, of course, the people with an issue, help them get better. So as we think about, that's kind of this continuum, and think about your populations where they align, then you can think about programs and services that kind of fit along there. Do I have programs and services that kind of fit with the well, the at-risk, the condition, and the complex groups? All make sense, kind of just laying the groundwork here for a little bit of a conversation to come. Social determinants of health. Anybody kind of buzzword these days? Yep, quasi-familiar. So it's interesting to me that this is such a hot topic right now, because it's always been part of what we've talked about in the, quote, old days. We used to call this SES. Anybody remember what SES stands for? Social economic status, which was basically social determinants of health. I don't know why now all of a sudden it's social determinants of health, but all good, happy to have it. So the idea here, though, is that, of course, we've known this, again, for a long time, but it's fine to just remember that what really contributes to people's health. And so while access to health care is important and genetics are important, there's a big realization that, frankly, the neighborhood I live in, whether it's safe, whether there's transportation, whether there's good food, whether there's good housing, all those pieces are important. I heard a speaker from the de Beaumont Foundation. I don't know if anybody knows that organization, but they're kind of like Robert Wood Johnson Foundation. And he was saying that he travels a lot, and so he decided to get a pet, though. So he got a goldfish. And this goldfish, he worked it out. He had it swimming laps all the time. And I don't know if you heard this guy talk, but he's a really good speaker. He goes, I got it coral reef so it could meditate, and I feed it the best food. And so this fish, and he went on a trip. He came back, and the fish was dead. And his son said, well, Dad, you have to clean the tank now and then. So kind of a little bit of a metaphor for, we can do all these things for our employees. They still go home. And if the home environment is not great, that's an issue. So what I find interesting, though, is there's a lot of talk about social determinants of health, and then employers are kind of going, well, yeah, but what do I do about it, right? So I have a public health background. When I went to school in public health, you kind of picked worksite health, school health, community health. And while they overlap, you kind of have your specialty. What's interesting is I started talking to employers, and I said, okay, there's this whole big conversation now about employer-community partnerships, involvement in the community, all those kinds of things. And I wasn't really buying it because, to our earlier conversation, I'm a bit of an ROI guy, and I was kind of thinking, well, what's the ROI on, I don't know what, helping, a school program, kids learn to read or something. So I said, all right, if we're going to we talk about diabetes or musculoskeletal or anything like this, and we talk about narrow networks and centers of excellence and condition management and all those good things, can we talk about housing, food security, safety? It blew me away. They all said, absolutely. All our people are in the community doing this already. They volunteer in homeless shelters. They're planting trees in parks. They're, doing all kinds of things. It's all about engagement. And by the way, we have foundations, we have community relations, we have all these things that we do in the community. We sponsor things. So as you think about kind of your full scope and your partners, the thing is that everybody's siloed. So one of the strategies these days that I've been working on is helping your health and well-being programs align with your kind of community programs and community service. And I don't know what do I have here? Oh, that's a build. So just think a little bit about that as you're thinking about, okay, where are we with our volunteerism programs? Where are we with what we sponsor in the community? How does that align with what we're trying to do with the health and well-being of our people? Okay, so speaking of health and well-being, things have changed over time. Yeah. When I was in graduate school, I was one of those guys coding those Scantron sheets. That's how we did health assessments. There was an organization, one of the big organizations was the Association of Fitness in Business. Wellness was fitness and, kind of those Jane Fonda workouts. And it was easy to count it. It was easy to understand it. It was very kind of physical in nature. But things have really evolved. And the reason that I really want to point this out is because when you talk about it these days, a lot of people think, wellness, maybe it's tainted or they have an image of what wellness is. And I think part of it is, and I'll talk a little bit about this, wellness has evolved quite a bit from wellness to well-being. It's really evolved from this idea of lifestyle, behavioral risk factors, to some targeted interventions where we got on the phone with people after they did their surveys and we try to help them change their behaviors. To now, it's all this digital, personalized, simplified recommendations that's very integrated with lots of other programs and services that's very data-driven. It's really very sophisticated, and there are a lot of pieces to it. But at the end of the day, we're getting closer to what a consumer would experience, when they're just purchasing Amazon, or if they're going to travel or what have you. That's what people want in their health and behavior change. It's morning, but everybody's following me so far? All right, so I'm going to keep moving a little bit. So this idea of wellness to well-being, I kind of mentioned that in the kind of the strict public health way of thinking about it, wellness is that study of those behaviors and lifestyles that put people at premature risk of disease and dying. So smoking, sedentary behaviors, stress, all those things put me at risk of having a chronic condition. Well-being is the study of those factors that increase the likelihood of me living longer and happier. So one is about what kills me sooner, and one is what helps me live longer and happier. So what I find, because it's in the old wellness model, there used to be spirituality and all these other pieces too. It was very holistic. And then we got very clinical about it, and it was all about biometric risks, and we lost track of kind of the well-being piece. But it's interesting, so as I kind of did this research, and there are lots of ways people talk about well-being, it's all fine by me. One of the issues is that it's just more relevant, right? Because I'm going to talk about engagement and why people participate or don't participate in the programs and services. But well-being is more relevant because you're talking about what matters to me, as opposed to, I took a survey and I'm going to tell you what's supposed to matter to you. So for example, this idea of get enough sleep, so interesting to me. We have a coaching program. So for those of you who don't know about United Health and Optum, we do a lot of this population health stuff. And when people sign up for coaching programs for decades, the number one coaching program is people want to lose weight. Always want to lose weight. Number one thing now, sleep. People want sleep and energy. Just curious, who got a good night's sleep last night? Anybody? Oh my gosh, hello, Ohio. This is a kinder, gentler place. When I travel, I do that thing, and there's like a couple people sheepishly say, yeah, I got a good night. And everybody's like, oh, I hate you. I'm so tired. People are out napping in their cars at lunch. So, but we know there's a lot of data around sleep. So good for you. That's one of the main things you can do to get sleep. In fact, I was at a meeting last week. I was at Google for 2 days at this kind of think tank lab. And very interesting conversation with some of these sports mental performance experts. And this doctor from the US national team. So she's the mental performance coach advisor for Olympians. And she was a very interesting speaker, but one of the things is, so what's the one thing we can all do to take away, right? We all want to be Olympians. She said, sleep. She goes, 7 for sure. I'd love it if you got 8. And if you're physically or mentally heavily active, get 9. Well, like, yeah, okay, that'd be good. I'd love to get 9. I got about 5 last night. So sleep is important. And then on the lower corner, financial security. Are any of you kind of doing financial well-being programs? Yeah, this is one of the fastest growing areas as well. The issue is that in the past, we'd say, oh yeah, well, we have Fidelity Insurance, or we have somebody who does our 401k for us. That's not what we're talking about. You've all heard the statistics about 50% Americans, $600 bill is going to throw them into an emergency. It's about budget. It's about 7 to 8 credit cards on average that people have, and that people are carrying a big balance on that. So how do we help people when they're worried about making ends meet on a daily basis? Focus on eating well or sleeping well. Not going to sleep well when I'm worried about finances. Even things like being active. So in the wellness world, being active is cardiovascular and weightlifting and all that. In the well-being world, it's get outside, be social, be consistent. So blue zones, anybody ever heard of a book? Yeah, blue book. So this is a very fascinating study about the places around the world where people tend to live the longest. So picture that guy in Sardinia, which is one of the places, old guy. He's just walking through that village every day, kind of waving to the crowd and, going to get his cup of coffee. And he's never done Pilates in his life, and he's living at 95. Same with eating well. Again, in the wellness world, it's calories and carbs and all of that kind of world. In the well-being world, it's colorful plate of food, moderate portions, glass of wine if you want it, be social, be mindful. It's a different message than we used to have. So when we try to understand why people are kind of reacting to our message, the well-being message can be a different message. Things like mindfulness, cut across, positivity, gratefulness, the social connection. The thing that surprised me is the creativity. The human being needs to be creative. If we're not creative, we get depressed. If we can be creative at work, that's great. If not, we come home, we find something to be creative about. So, very interesting stuff. Okay. So as we shift now, we say, okay, we just talked a little bit about the value proposition. We talked a little bit about population health overall, and then drilled down into well-being. What happens to me is I'm in a lot of meetings. I'm a data guy. We point out what are the high-cost claimants, what's the medical spend, what's the RX spend. We do all these things, and then we open our jacket and we say, here's all the programs and services we want you to buy. And the client says, yeah, no, that seems good, but how do you get people in them? Engagement, number one question, right? So for me, you can have great solutions, but if you don't have engagement, you don't get value. 100 times 0 is 0. So we spent a lot of time thinking about engagement. This is where we're going to start to get to the behavior change concept. One of what I found so interesting about this research is we know a lot about companies and how to get participation and engagement, and I'll share a little bit of that. But I spent actually a couple of years doing research on this, both internally and externally. What do we know about engagement? How do we drive it? How do we understand it? And what I found was the first thing is it's super personal. You really have to understand that it's humans. I don't even like this term consumer anymore. It's just people, right? Consumer just kind of makes it so quantitative and cold, and it's more than that. And in fact, if you're in a scarce environment, you're financially worried, you're not thinking about drinking 7 glasses of water a day or parking farther away get your steps in. Health literacy, 1 in 10 people are health literate. Can't navigate the system, can't read insurance policies and benefits and understand how to go about things. Social determinants of health we touched on. Again, this whole idea of you tell me your zip code, it's more than you tell me your genetic code. Things around compassion, we really understand, and there's a great book by Monica Warlin, and she has a colleague, and they wrote the business case for compassion. So we're all trying to have better customer satisfaction. We're all trying to have better employee relationships, and yet we're not allowed to talk about what's going on in each other's lives. In many cases, it can get a little awkward. On the other hand, I really like it when I'm connected enough to my colleagues and my clients that we quasi-care about each other, right? And everybody has physical and emotional pain. Things are happening. So how do we go about that in an appropriate way that we can still connect, which is the next point, which is social connection. There's a lot we know about social connection, social isolation. Again, bold statement, but if you smoke and you're lonely and isolated, I'd rather you get a friend than quit smoking. It's a major, major factor in death, in mortality. So we do a lot of work around trying to understand what's people's social connection. And then this attention war, again, I said I'm in the Silicon Valley, but it's impossible. I really appreciate, I haven't seen too many people glance at their phones, but it's impossible to not be disconnected these days. So how do we get people's attention? So I share all this again just to make it human. It's a real problem. Again, I was at this meeting last week at Google for 2 days, and we're talking about all this stuff, and I just said, wait a second, let's just remember they're people. The number one thing for Google, they did a focus group to try to understand what was going on for the Googlers. That's what they call their employees. And all the issues around them, because you'd think they're fed and they've got laundry service, they've got all this great stuff. What's the most stressful part for them? The commute. The commute's horrible. So they have all these buses and everything, and they're trying to address that. So we just really have to understand it in a very basic way. So I said I'd just touch on this, because I really do want to get to some of the behavior change science. I'm doing okay here, yeah. When we do the research, there are really 5 things that drive engagement into the programs and services of which you all are responsible: communication, culture, incentives, design, and experience. And those drive people into the solutions and the interventions, which in turn are about behavior change, which then get us all the outcomes that we talked about, the value that we talked about. So, by the way, we already mentioned this. These slides are going to be available to you. Apparently, if you haven't had enough already, you can watch this again at some point. So I won't go through every point here. But what I'll tell you is, again, communications have changed drastically, from health education to patient education to consumer marketing to now what I'll call social movements. So really think about how you do communications in a bigger way, in a social media way, in just a multimodal modern way that isn't just a campaign and informational. Culture, it's the secret sauce. All things being equal, culture is going to be what's going to drive it all. Your leaders, some leaders are more open than others, but whether they blog their journey or challenge the group to do as many steps as they do, or they just, advocate it in staff meetings and amongst their leaders. And peer leaders, so your immediate leader is the most important determinant of your behavior. So if you're in some organization and the top gal says do this, but your immediate people don't, not going to do it. Incentives. Anybody offer incentives for wellness activities or things like that? Yeah. So it's evolved quite a bit. It tends to be very financial and delayed and individual. We could have a long conversation about it, but what I will tell you is make it group. Make it, if we all do this, if we hit 50% participation in a survey, then we all get something. Or better yet, we donate something to the charity of choice. Philanthropy and doing things for others tends to be an amazing motivator. Connects on a lot of different levels, and it tends to be more powerful than just a financial thing. I'd much rather give my 50 or $100 to, feeding kids or housing people without homes than, whatever that translates into a check over 26 pay periods. So think about shifting how you do incentives. Has to be a great experience, has to be a great design. So behavior change, let's get down to it. Behavior change is hard to change behavior. I'm going to walk through a few, a little bit of the science of it, but then hopefully we'll have a little bit of time to talk about it. The thing about it is we do know how to do it. There's a lot of young people in the room, but anybody remember this campaign? Yeah, sorry to call you out. You were teeny when this was out. There was a time, I remember, litter was like big deal. Literally throw the bag of fast food out the car window or just drop it anywhere. You don't litter in this country. Not much. We were able to change that, right? And part of it was this emotional appeal. Part of it was to come to an acknowledgement of something greater than ourselves. We want to leave a legacy. We feel bad that maybe we destroyed it for people who really cared for the planet, but we want to get back to that. So this campaign really, really hit something more than just, hey, don't litter. It's bad behavior. Smoking, again, we've made a lot of progress. We're slipping a little bit with the vaping thing, but we made a lot of progress. And part of it is we learned a lot about communications, that fear wasn't what it was always about. Again, this emotional connection, but we also know that it had to do with policies and taxes and other economic things. So, but we were able to change smoking behavior, tobacco use behavior. Again, it wasn't that long ago when some of us are like, seatbelts, what's that? And kids sitting in the back, that, big American cars had a lot of room to just stretch out. I'll just say that. Now, you buckle up, there's car seats, there's everything. So again, we changed that behavior. I mean, we used to put it on the health risk assessment until we just like everybody says they buckle up. It's just not a differentiator anymore. Helmets, I'm a cyclist. Took me a long time to get, literally, I was going to say get my head around a helmet, but get my helmet around my head. But now it's common. You see people, just little kids on skateboards. I grew up as a skater. They didn't wear helmets. Now they're all got it all going on, right? Recycling, we're always looking, where do I recycle this? Don't you have 2 bins? Don't you all that? So think about how we've done this and how can we go around healthy behaviors? So some of the lessons here, mass media, taxes, peer pressure, what's relevant to you. These are all things that you want to try to translate to the workplace. And that's why I liked the workplace. That's why I picked it for my kind of path early on, was because I thought we have a lot of influence on this culture, on these messages, on building a physical environment, on, in a sense, placing taxes. Even with, cafeterias now, we subsidize the healthy food in a lot of places. So a lot of influence, a lot of opportunity to influence that behavior. So a boss of mine at one point said, Seth, you're all into this behavior stuff, but you're way too academic, and I don't get it, just what's the bottom line? I thought about that for a second. I said, well, ultimately, behavior is driven by avoiding pain and seeking pleasure. So that's just, so if you really want to boil it down, think about your own behavior, and you could boil it down to those 2 things. And that pain and pleasure may be more psychological than actually, physiologically, but at the end of the day, it has a lot to do with that. As you move up the hierarchy, though, and you think, well, there's a lot of stuff I do that's not about pain or pleasure, like, I just automatically, drive here or whatever. There are things that you do routinely that you don't have to think about. So think about that too. Are there ways, as you're trying to change behavior, your own behavior or others, that you just make it, as they say in behavioral economics, the default? It's just routine. I don't think about it. I don't want to think about it. Boom. And then it's interesting, but the main thing that we're trying to do is the hardest, which is help people with delayed gratification. Oh, don't do that now, because in 20 years from now, you're going to get to live longer. Or you won't be as, you'll be healthier, all that. People are not wired that way. That is just not in us. So we need to really figure out what is the immediate short-term pleasure or pain avoidance. And on the other hand, this internalization, trying to make it who you are. So from I'm a runner, from I run to I'm a runner, to I eat healthy foods to I'm a healthy eater. It's just who you are. From I don't smoke to I'm a non-smoker. It's just trying to get people, once that they switch into who they are, that internalization, it really becomes part of the behavior pattern. So the other thing that I've kind of done is say, okay, there's a lot of behavior change science out here, and it's overwhelming. So how do we really want to think about this? So I took all the literature that I was aware of. There's a ton out there, and it keeps getting refreshed, and I have some of this, but kind of thought about it to say, think about behavior, and the reason that I think this is important for all of you as kind of purchasers of programs and services, of stewards of this population that we talked about, where behavior is so important, and people are, in a sense, pitching you things, or you're thinking about things. Well, what's the behavior change science behind all these programs and services and your, kind of strategy? So think about it in terms of 3 big buckets: awareness, skill building, and maintenance. So typically what happens is programs jump to the skill building. Oh, you're diabetic, let me show you how to have that kind of diet you need and monitor your glucose. You're an asthmatic, let me show you how to use a peak flow meter. Oh, you're exercising, let me show you good exercises. And we jump right to that, but frankly, we don't even use the best science for that. This model says, let's back up a second. Let's talk about what's in it for you. Why are you even bothering? Because frankly, there might be some pain involved. It's not always completely fun to change your lifestyle, at least in the beginning. So we ask people, what do you think the benefits and barriers to doing this are? How do you weigh the pros and cons? But in the end of the day, what do you care about in life? So do you care about community? Do you care about giving back? Do you care about being a role model? Do you care about having a lot of energy so you can have fun and whatever that might be? We need to know that. Why bother? Why are you going to bother going through this? Then we get to the skill building, and although we don't always act like it, we're adults. Adults learn differently than kids, so adult learning behavior theory is very helpful. And that's where all these small changes and helping people have little wins and not being humiliated when they try something new. There's a lot of techniques that go into adult learning theory that roll into some of the other science that I'll talk about in a second. And then maintenance is the classic, because people say, well, that's the hardest piece anyway. And, I would say, yes, but we know a lot about it. And frankly, it's the most important part. And one of those is that internalization that I talked about, but the other is really designing for maintenance, whether it's designing your physical environment, your social environment, designing for failure. It was interesting, I was talking to one group about this maintenance thing, and they had done a project for smoking cessation. And the idea is that when smokers try to quit, I don't know if anybody in this room has tried to quit, but one thing that happens is okay, you get rid of all the cigarettes in the house, everywhere, all your stashes, you get rid of them, and you quit for a while, but then you really want to smoke a cigarette. So what do you have to do? You go down to the store. In the old days, there was a little jar, and you could actually buy one cigarette. But you can't do that anymore. So you buy a whole pack of cigarettes. Well, I just bought a whole pack of cigarettes, and it's like $6, $7 now. I'm going to smoke the whole thing. So they designed a little box with one match, one cigarette, and, some kind of inspirational stuff to okay, just because you smoke one cigarette. But it was designing for failure. It's going to happen. So in the maintenance phase, you really have to plan for that. So awareness, skill building, and maintenance, think about it as you look at your program design. Think about it as you're approached by other kind of program opportunities. So health literacy, I just can't help but talk about this topic. I just don't get why it's not talked about more. It's not just reading level. It's clear, simple language. It's making sure people understand what's the call to action and really helping people understand what's in it for them. There's so much data on how doing things within a health literacy context will drive better outcomes. So I just also encourage you, as you're looking at materials, as you're, again, assessing programs, services, resources, put that health literacy filter on. I'll give you one example, which is advocacy programs. Many of you heard about, we try to do these kind of front-end advocacy, person will help you navigate the system. And for me, they're fine, but they're a symptom. They're a symptom that people don't have health literacy. And so what do? What's the saying? We give the man the fish, we don't teach them to fish. So why wouldn't we really try to help people understand how to navigate the system, understand the system, really provide health literacy skills, as opposed to this idea of kind of just one-time information. So think health literacy when you're thinking about behavior change. Behavioral economics seemed like it burst on the scene, I don't know, 10 years ago, maybe longer. We've even got, Kahneman and Tversky, Nobel Prize for that. It's really what we used to call social psychology, but it's a blending of kind of two disciplines, behavioral sciences and economics. And there are a few principles here. So the things like loss aversion, the idea that if you have something and someone's going to take it away from you, you don't like that as much as the promise of getting something. So if you do this, I'll give you $100 versus here's $100. I'm going to take it if you don't do something. Right? So my daughter's now graduated from college, but when she was younger and doing sports, she liked volleyball. And so she was serving, and it's the one thing that drove me nuts, right? That's like the only thing you really have control over. And so these girls are playing volleyball, they're serving into the net, and I said, all right, tell you what, I'll give you $1 for every time you serve a good serve. And that didn't work so well because, I don't know. But I said, here's $10 at the beginning of the game. It's yours. Every time you miss, I'm going to take $1 back. She became the best server in the league. So one thing she could do. She did a lot of other stuff, not so good. But the idea is that, okay, I have this money. I'm not going to lose it. So there are ways to think about that in behavior change. Optimism bias, that we always think things will be better. Then, so we kind of tend to downplay what we need to do. A number of these things that I'm going to try to bring to life here, but within behavioral economics, they brought a lot to us. So this idea of framing, so framing a choice. So one of the examples of framing a choice is pricing, right? So the whole online thing was very new for a while. So they were trying to figure out, okay, you can have the print version for X, you can have the online for Y, or you can have the print and online. And they kind of figured out how to frame the pricing so that, okay, I want both. And that'll be the most expensive, but it's just incremental. So things like that, things like this, kind of the power of zero or free. Okay, so again, it's this idea of buy one, get one free. Now we see a lot of buy two, get one for 25 off. I mean, it's kind of, you have to do the math, and then you go, well, that's not worth it, but I just heard that I'm getting something cheaper. So, so marketers are great at taking advantage of these behavioral principles. But think about it in your programs and services and what you're trying to pitch to people. So these, as you can see some of the examples, but, offering free meds for, compliance to, various treatments. We do this with diabetics all the time. Social norms and market norms. So we all know, I'll just call it peer pressure, right? Social norms. We do what everybody else does. And so things like volunteering and if everybody is helping out, and that's where I talked about this incentive thing. I really like building cultures that kind of create a social norm as opposed to just very individualized, and we really don't know what everybody else is doing without revealing kind of, personal health data. So the idea of, trying to really, for example, what's our culture? How do we, so for example, walking meetings. So some organizations are really big on walking meetings. They're great. In my opinion, you can see I'm a walker. So other things that are even, so it's interesting, the culture. I try to notice this stuff. So everybody's on WebEx or whatever, conference calls, right? And in our organization, you can choose to do the video or not. And a lot of us work remotely, at least some of the time. And a lot of us also complain or, experience kind of not being connected to each other. And yet we don't want to turn the video on because, we're just at home and we're not all totally buttoned up, right? On the other hand, it's every time everybody turns on the video, one, it kind of forces you a little bit to be present in the meeting, but two, you kind of connect. It's kind of nice to see people's faces, right? But it's a cultural thing. It's a protocol. It's a habit. So when I'm on the call with my data nerd reporting friends, they've all got their videos on. When I'm with the salespeople, not so much. It's interesting. So there are social norms that you can create around health and well-being, around culture, around connection. The power of expectation, satisfaction may be influenced by cues and expectations. So again, what you expect has a lot of power. So this idea of, testimonials are very, very powerful. Again, making things human allows me to understand. I mean, in the early days, again, we were thinking, why aren't people taking advantage of coaching? We have this great service, personalized coach. Who knows what a coach is? I don't know what to expect. I'm worried about it, Or it was interesting. I was talking to, a friend of mine's wife, and we're talking about fitness and exercise and all this stuff. Well, she's never done that. She's not an, athletic background. So just doing this, she doesn't know what to expect. She doesn't want to sweat. She doesn't know what to wear. She doesn't know how to do her hair. I mean, all this stuff that I would never think about, but it's real for people. So you kind of have to help them understand what to expect, what's going to be like, help overcome some of those concerns. And a lot of times when someone like you talks about their experience, that helps you go, oh, so-and-so did it. I guess I can expect it'll be okay. People tend to be less honest if they're having something to gain and they think it won't be discovered. So there's all these, social scientists create all these really perverse little games with what they call cohorts, and then they have confederates, is what they call them, the guys who are actually sneaky. They're not really one of the subjects, but they do something that's not totally straight. So the idea of, so this is, I think, a big one is the non-smoker policies. For a long time, it's like, okay, we're just going to trust people, even though they're $600, $1,200 for a smoker's discount. Yeah. And you know what? For the most part, people are very honest about this. On occasion, somebody's trying to game the system. It's going to happen. The same with health surveys. It's very interesting because a lot of, especially senior level folks, don't really believe in self-report information. But what I try to remind people is that it's the time one, time two that matters. So I might actually have 6 drinks a night, and I'm going to report 4 drinks. But if I reduce it by 2, and the next time I say 4, that's great, because all I really care about is the delta. So people are what I would call very consistent liars. Thanks. So I kind of remember, and that's okay too. So I think I'm getting pretty close. Oh yeah, so one last thing, and then we're going to open this up for some questions. So I hope that's on your mind. Start thinking about questions. So this engagement thing that I started talking about, and then I circled around to behavior change. For me, it's an interesting topic because it's one of these things where I studied it, I told you about it, We talked about how to increase it. We never defined it. How do we measure it? What really is it? So it's not what it used to be, which is that fitness class or the funnel of qualified, identified, outreached, enrolled, engaged, etc. That doesn't work now with these multimodal programs that are holistic and digital and some talk. And how do we measure that? 3 calls isn't going to get it done. So the first lesson was it's got to be across different products. So engagement is different for different products. So population health, preventive services, and clinical. So engagement for clinical programs might be work with a nurse or a clinician on a regular basis, whether it's digital or telephonic. In a population health, it might be take a survey. That engagement's very different level of effort. Then the other thing is, instead of it being kind of what I'll call interval, like, you know, from like 1 to 10, it's more categorical. Think of engagement in 2 ways. Think of it in terms of administrative metrics and value metrics. So the administrative metrics are those metrics that are very transactional and operational. Did I log on? Did I enroll? How many clicks? How long was a person on the phone, or how much did they interact with what things? All very good, and oftentimes what a vendor will report. Oh yeah, we can get 90% engagement because, well, it's pretty easy to get that. The value metrics are those metrics, let's just fill this whole thing out. The value metrics are what I'll call the dose, the thing that you need to get the outcome that's promised. So if I'm trying to get somebody to close a gap in care, I need them to talk to a nurse at least twice and track their, you know, their blood pressure for at least 4 weeks. We have a weight loss kind of program called Real Appeal. We know that if people do it for 12 weeks, they do the virtual classes, they do all the jazz, on average 3% body weight. 24 weeks, on average 5% body weight. We know what the dose is there. In other cases, we don't know what the dose is. So I would again encourage you as purchasers and just kind of savvy monitors of your programs, think about metrics in terms of what are the administrative, which are different from the value, which are different from the outcomes. So with that, it's morning. It's kind of getting warm in here. There are big pots of coffee on the table that you need to take advantage of. But we have a few minutes for questions and conversations. So love to do that. Yeah, thank you. There's going to be mics circulated because I guess we're trying to hear each other.
So at the outset of your talk, you referenced sort of the ROI mindset versus human capital, different schools of thought. I'm wondering how much of the macro economy drives the thinking. That is to say, a tight labor market yields a greater skewing towards human capital versus the opposite, just in terms of the economy. Yeah,
thank you for that question. I certainly think that a tight labor market drives some of this. I also think when healthcare costs continue to drive up, you know, we're happy that they're at 4, 5, 6% trend versus 12. But, you know, I think what really drives it is we're able to show the data. So more and more studies are being able to show business performance metrics. So while some studies were able to show the relationship between healthier employees and reduced absenteeism and, quote, presenteeism, for example, we did a study with an airline, and we were able to see that better health decisions was related to better on-time airport departures, fewer mishandled bags, better customer satisfaction, and fewer accidents. We talked to all our employers, because the thing is, it's different across every employer. What are your business metrics? Could be sales per square foot in others. It could be, you know, whatever those metrics are, delivering packages on time. So while I think the macro is definitely a factor, what I think is really a factor is the data. And we've got more and more of that. Yeah, thank you.
Back on the wellness, well-being slide, you had listed 8 kind of clusters or categories. Have you done any research to understand if there's any correlation in terms of which one drives another? And I'm really interested in the emergency, kind of the financial security. And that could we redirect some of our wellness dollars that we spend on programs to financial security, and would that yield a better result for us as it relates to well-being?
Yeah, so what I can tell you is we did a study, I think it was last year, of consumers and what they want. We asked them, first of all, what do you think, what this well-being thing is being pushed on you, we could say. What do you think of it? Is it good? And then what do you want from it? The number one thing they wanted from well-being from their employers was financial security. That's why we all work, theoretically, is to get a paycheck. And you know, there's some other things about it, hopefully is fulfilling and all good, but part of it is they wanted that. So financial security does seem to be a major stressor. One could call it a root cause. I really feel like when people are financially stressed, they're not thinking about the other things they need to do in their life. So we see a lot of examples of programs and services around that now. Some dollars potentially redirected, but we're seeing even creative apps, like for those people that are on variable pay, there's a program called Even that helps you even out your pay. And the employer, let's say, you know, you make $500 a week. 1 week you make $400, 1 week you make $600. They'll give you $500 every week, knowing that, you know, things will balance out, because they want to avoid people going to payday loans and all the other things that happen. So I think there are a lot of creative ways to kind of help financial security, in addition to teaching people how to budget and give them those tools. Yeah.
Could you talk about any work that you're doing to take behavior change concepts out into the provider market? So we talked a lot today about the workplace, but we know that there are a lot of issues with the way that medicine is practiced out in the marketplace. So curious how Optum, United Healthcare, is taking that out to the provider community.
Yeah, so I am spending some time in the provider space. I would say the first principle of behavior change for them is one of those behavioral economics principles about just making it the default. So, for example, when it comes to pre-authorization, we've built a tool on the RX side that just lets that doc know whether the medicine that they prescribed has a pre-auth and can they get it, so the person doesn't then go to the pharmacy or wherever, pick it up and realize it wasn't auth and there's a big bill. So one of the biggest things in the provider space is, look, I'm stressed, I got just not a lot of time with my patients, don't put more on me, but if you can make my load lighter or build it into my load, that's going to help me with my behavior. So we are seeing some of those types of interventions that just kind of fit the process a lot better. Some of the diagnostics that some of the docs help with, again, I think drug interactions is one of the straightforward ones, because those are pretty complicated to keep off the top of your head. But even some of the diagnostic software now that can help providers acknowledge what's best practice these days and keep up with it are part of what we're doing. I would say that there's a lot of room for improvement, for sure. And it's a lot of culture. For me, it's a lot of culture. And I think as the next generation of docs come in, we'll start to see that shift. We have another couple minutes. Challenges, free consulting here. Get your time. What are you guys working on? What's a big pain point for you? Is anybody working on mental behavioral health? Stigma? So I know I'm just about out. Let me tell you just one little piece here. So this conversation around mental behavioral health, very interesting again. Ask it a benchmark of employers, go around the table, hear what they're working on these days, and I would say 90% are at least trying to address this amongst other issues. But what was interesting is they were describing mental and behavioral health issues as stress and financial and life circumstance issues, as well as kind of clinical. So as you try to open up the conversation about mental behavioral health, it's not all about opioid addiction. It's about life is hard. I'm trying to figure it out. My kids are launching, or my kid's just starting school, or I'm just in a relationship, whatever it is. It's normal stuff. And there are some really interesting campaigns out there about it's okay to not be okay. It's the old, some really cool stuff about I'm fine, are you? Kind of stuff. So I would just encourage you to start to, look at some of the literature out there on this topic. And, maybe that's part of what the coalition and others, you've got some people, mental health specialists, I think, on staff. So big topic that is related to all the other big topics you work on. Yeah, please. There's.
Aspect of
Yep, there it is. Surprise.
the social aspect of well-being. So the community where you live, the neighborhood that you have to drive through, the route that you have to take to get to work or get home. Can you talk a little bit more about, I was very interested when I started to see that, and now I'm seeing more commercials about that also, is how impactful well-being is being impacted by the social environment of home as opposed to just work.
Absolutely. So, again, I think it's a tremendous recognition that the fish can't change without the tank and the water around it changing. Really hard to have the employee come home into an environment where the food and the, everything else, TV blaring, all the screens aren't down, let alone the neighborhood, go take a walk after dinner. No, I don't think so. Their sidewalks aren't good, I don't feel so safe, whatever it may be. So what I find interesting, though, is that a lot of employers are very vested in their communities. And they're doing things to create greenways, and everybody comes out on a weekend and plants trees and makes a great walking path, or knows that the schools need scholarship funds, so does a big walk to raise money to get some kids to go to college, or has a reader program. So what I'm finding step one is just inventorying. What are we as a corporation doing other than United Way fundraising once a year? And it turns out companies every size company is doing a ton in their community, and the employees love it. They feel really good about that. So again, my strategy is let's heighten that awareness, how important that is, but let's get all the different departments in the enterprise connected on that topic. Yeah, comment in the back.
So I know Optum has pulled a lot of data on obesity as a chronic disease and a major financial spend for employers. Can you talk about the movement from more the prevention wellness aspect of obesity, of the healthy food and exercise, to treatment of obesity?
Yeah, so the way I think a little bit about this is, to your point, it's a bit of a continuum. I would say our organization, the United UHG side, when they tackle this, very clinical. So we've got some programs that are around people with a true metabolic issue. We've got kind of centers of excellence, how to help them. As you start to move down the continuum and you have kind of weight loss programs like a Real Appeal for us, or the Zapongos and the others that you may have heard of, that's part of it. But for me, it's bigger. At the end of the day, it's all about what you put in your mouth. And so how do we help people from some of these behavioral science principles affect that? How do we partner with grocery stores to subsidize less expensive food? How do we help people understand how to just cook, raw foods, fruits, vegetables, etc.? So one of the things, this is like a little simple play in my mind, that hits a couple of boxes, which is the data for me is very troubling that people don't cook at home anymore, like very few meals. So, okay, let's just think about that for a second. So what does that mean in terms of the food out that they're getting, which is probably not the most healthy? But then let's pick the reverse. Let's imagine 2 times a week you say to your family, your partner, whoever it is, yourself, I'm going to cook at home. So what does that mean? That means I've got to plan a little bit. I've got to think a little bit about it. I've got to pull out a cookbook or whatever, or go online. I've got to shop for that food. I've got to learn about it. But it also creates the opportunity to connect with people in your family. So for an hour and a half that evening, we're going to cook together. We're going to talk. We're going to laugh. We're going to clean dishes. And maybe when we eat, we're even going to put our devices down. So it's social connection. It's learning how to eat and look at your food and enjoy it and move slower. So I think there are some little kind of campaign kind of things, as well as big macro things where we're trying to work with grocery stores to create cards where people can kind of get discounts on certain foods, to policies, to just education about what food is. So there's a multi-pronged strategy, and one of my favorites is to the comment around the provider that docs are not trained in nutrition science. So I come in for whatever my ailment is, and they're not talking about what are you eating. That's kind of one of the first things that maybe they should. So for us at UHG, we are creating this whole continuum with a whole set of kind of policies, solutions, and actions around each area, from prevention all the way to the clinical. I think we're close to out of time, Chris, so thank you very much. Appreciate it.
Yeah. There you go. Thank you, Seth. Do you want to go up there? Or do you want to...
So thank you, Seth. So I wanted to spend just a couple minutes here at the end to talk about, just give you an update on our progress here at Employers Health. And I thought it'd be good, to step back from a macroeconomic perspective and thinking about, what's important to us. And when we look at company budgets, when we look at school budgets, when we look at state budgets, when we look at federal budgets, the dollars that we have available to invest in those priorities are constantly being sucked up by rising healthcare costs. And so as we think about what we're trying to do here at Employers Health, I liked this statement that we had in our recent newsletter, that every dollar that our clients waste or use inappropriately on healthcare expenses is a dollar that isn't invested in payroll, capital improvements, or passed along to shareholders. For government clients, each dollar could be put to better use in schools, parks, and infrastructure programs. And for employees and their families, it's a dollar not available for things like vacations or retirement, planning for education, or even day-to-day expenses. As Seth mentioned, the study that a $400 or $600 medical bill would put a lot of families into dire straits. So as benefits professionals and fiduciaries of plan dollars, it's our responsibility to ensure we are spending those dollars in a prudent manner, and it's also a worthwhile pursuit that brings purpose to our shared work. When we think about our aims at Employers Health, our guide is our GPS, growth, performance, and satisfaction. And so talking a little bit about where we are from a growth perspective in terms of both team additions and then also from growing our membership base. So as we grow our membership base, we obviously want to continue to provide a high level of service and satisfaction to all of our clients. And to do that, we have to invest in new talent and new members of our team. And so you can see we hired 6 additional individuals, 6 additional professionals over the past 12 months, ranging from account management to data analytics to graphic design and marketing. From a PBM perspective, our goal from a growth perspective each year is to get $200 million in new pharmacy business. So that's a pretty big goal when you think about it. A lot of coalitions that are out there or other group purchasing collectives don't have $200 million in total. So the fact that we're trying to add that much in additional revenue to our program each year is a big task. From a performance perspective, we want to keep trend flat or negative. And then from a satisfaction perspective, we want to make sure that we continue to deliver high client satisfaction. And we do that through our own client satisfaction survey that we put out every year. So thank you to those who respond to that. We take the information for that, and that really helps in not only judging how we've performed in the past, but it also helps guide how we plan to add value to you and your organizations in the future. So from a membership growth, 28 new clients this year, about 175,000 in new covered lives to our program, and about 203 million in pharmacy spend. So just got over the goal. If you take this year and last year, it's up over 400 million in new pharmacy spend that we've added to our program, which is really phenomenal, and a big thank you to our entire team, because it really does take the entire team to make this happen. And thanks to you, our clients, particularly those that serve as references or make referrals. That is very happy. Satisfied, happy clients are our best sales tool as we're out in the marketplace trying to grow our collective influence. From a performance perspective, I've mentioned PBM. We continue to have our relationships with Optum Rx and CVS Health. And I mentioned earlier this year, we did a lot of news releases about it, that we added a pass-through deal with Envision Rx. And so that'll be up and running January 1st, 2020. We also are looking to move beyond just the pharmacy space. We realize that while pharmacy continues to be a growing area of spend and concern for employers, that it's still 25 to 30% of your total cost that you spend on healthcare. And so we have a new relationship with United Healthcare, and we were out talking to employers towards the middle of last year about that new initiative, and we'll continue to talk to our clients about that initiative, really with the idea of if we can get employers to utilize a common supplier or a common carrier, then we can start to do some unique things, both at a macro level and then individually within certain regions where we have pockets of employers that participate. We also continue to try to drive participation in our behavioral health and EAP service, which is CompPsych, Delta Dental, which is available for employers here in Ohio, and then from an IMED perspective in our Vision program. Regardless of whether it's medical, vision, EAP, or pharmacy, our collaborative value, or the value that we deliver through collaboration, is really predicated on three things. And it's getting better outcomes, a better experience for both those that are managing the plan and for those plan participants, all at a lower cost. So if we can improve outcomes, improve the experience, and lower the cost, we know that we can deliver greater value to you and your employees. And so how do we do that? Through contract management. Our number of attorneys on our team that manage our contracts on a daily basis, that are there working behind the scenes on your behalf. The service excellence. So again, a lot of work that we do behind the scenes with our supplier partners that a lot of our clients don't see to make sure that when we do come out and are face-to-face with our clients, or when an issue does come up, that we can get it handled quickly and effectively. And then from a utilization management perspective, we know that equipping you with the information needed to make wise decisions around plan design and how to better manage your population is super important. And so we continue to expand our team that are available as experts for all of you. And then finally, satisfaction. So meeting our promises. I mentioned the member satisfaction score. We try to achieve over a 4.6 each year. 4.6 means we're getting more 5s than 4s, so we strive for 5. This year it was 4.73, and if you look back over the 6 years that we've been collecting or doing the survey, we've exceeded that benchmark of 4.6 each year. So thank you again to all of you that work with our teams to make that a reality. 100% of the survey respondents plan to renew, and 100% would recommend membership to Employers Health. And then finally, one of the big areas in terms of delivering value, the annual market check. I wanted to mention this because we recently sent out the market check results for this year. Dave Aldrich's on our team, really works tirelessly across the entire year. Once one market check ends, the next one begins. And as the marketplace for PBM continues to evolve, it means we have to continue to be thinking about not only what's worked in the past, but again, what do we need to do to position ourselves well for the future. And so you can see from an average book of business perspective, the results from the market checks going back to 2016. So 7%, 5.96, 5.4. And that's really where a lot of the value in our contracting model comes into place, because if you pay attention to, for example, a lot of jumbo employers went out and collectively worked together, and they were kind of beating their chest about the fact that they had saved somewhere between 15 and 18% on their pharmacy spend by doing an RFP. And we know that the market didn't move 15 to 18% in that 1 year. And so the question isn't, what did I save today? But it's also, what did I miss out on over the past couple years? And so I think you can see that this model and this strategy for delivering pricing improvements through the market check process definitely delivers and makes sure that you're getting the most aggressive deal that you possibly can for your organizations and for your plan participants on an annual basis, not just when you go to RFP. So again, growth, performance, satisfaction, if we look at all three, we're very happy with where we performed this year. And again, I would just say thank you to all of you for your contributions to that success. We have big plans for 2020 in all of these areas, continue to make investments, again, in our team and in the resources that we have to come out and help you deliver additional value. So any questions for me? All right, well, on behalf of the team at Employers Health, again, thanks for spending part of your morning with us. Have a great Thanksgiving, and if we don't see you beforehand, have a wonderful holiday season as well. Thank you.